Okay. Hi, everyone. Thank you for joining us this afternoon for our February ACEs Quarterly. This quarter's presentation will be about the interaction of adverse childhood experiences, opioid use disorder, and overdose. Thank you, everyone who shared their name, their role, and their organizations. Thanks for being here this afternoon. As you listen to the presentation, if you have any comments or questions, please feel free to type them in the chat. And after the presentation, my colleague Emily will facilitate the question and answer time. And if you have any comments that you just want to share out loud, feel free to raise your hand as well. So now to introduce our guest speakers. All three of our speakers this afternoon are from the Snohomish County Health Department. Brenna Smith started at the health department in August 2021 as the opioid outreach coordinator through AmeriCorps Vista and was hired as a healthy communities specialist in 2022 to continue her work in opioid misuse and overdose prevention. She holds an MPH from Oregon State University and became a certified health education specialist in 2021. When she's not working, she enjoys snuggling with her cat Ferguson, reading, baking, and playing board games with friends. Juliette D'Alessandro has been a healthy community specialist with the health department since 2016 and holds an MPH and MSW from the University of Washington. Her work has focused on substance use prevention, including youth marijuana and tobacco prevention. Since 2019, Juliette has coordinated an opioid response project and consortium serving rural Snohomish County communities. When she's not working, Juliette loves to read, cook, garden, take walks, and spend time with her husband and their cat. And Abby Jernberg is a healthy community specialist at Snohomish County Health Department. She holds a degree in public health, global health from the University of Washington. For the past 2.5 years, her work at the health department has focused on opioid overdose prevention, harm reduction, and surveillance activities. When she's not working, she enjoys playing board games with friends, going on walks, reading, and listening to Taylor Swift. So thank you all to our guest speakers for being here today, and I'll pass it off to begin their presentation.
Thank you, Melinda. So hi, everyone. I'm Juliette, and I will be kicking us off today. So today we're talking about the interaction of ACEs, opioid use disorder, and overdose. So our objectives for today, sorry, my slides on my side are going slow. Our objectives for today are to gain some context around opioid use and overdose in Snohomish County through data that we have available to us. Understand the relationship that exists between ACEs and opioid use, examine some relevant risk and protective factors, and then understand what Narcan is and learn how to use it to reverse an opioid overdose. So I will kick us off with some data. Feel free to, if you have questions about any of our data, feel free to drop a question in the chat. And we will do our best to address it. I believe Sarah, our fantastic epidemiologist, is on this meeting as well. So she can probably answer anything that is more technical than my ability to answer. And also just please bear with us as we start with kind of the more depressing side of things. Talking about overdose deaths right off the bat. So just to kind of get a sense of what the state of opioid overdose looks like in Snohomish County in recent years. We are first sharing some data around opioid overdose deaths just from the 2017 to 2021 time period. This data comes from the Snohomish County Medical Examiner. And I think the biggest takeaways from these 5 years of data is that you can see a really clear increase in overdose death as we've gotten closer to this current year. So in 2017, I'm looking at the darkest bar on here, that's total opioid or overdose deaths, just total opioid overdose deaths. In 2017, it was about 100. And by 2021, that had just about doubled with 198 overdose deaths. Data for 2022 is not yet finalized, but in the little call out box kind of up on the top corner there, You can see that the totals through September of 2022 were 140 total overdose deaths due to opioids. And that data, those numbers will most likely increase, or will absolutely increase once we have the final months of the year included in that, and once all of those reviewed cases are finalized. So most likely we are looking at 2022 being on par with, if not higher than 2021 for total overdoses. And then I think the second big takeaway from this slide is the breakdown of overdoses due to heroin versus overdoses due to fentanyl. I know my wonderful colleagues will talk about fentanyl a little bit later in our presentation, and I think most likely most of you have at some point at least heard of fentanyl mentioned in terms of the current opioid crisis. But fentanyl, especially in the past couple of years and even more so today, is really driving overdoses. So you can see that in 2017, there were about 24 overdose deaths due to fentanyl, and in 2021, that was 158, which is about about 80% of overdose deaths. And for 2022 of the data that we have so far, it was about 87%. So that continues to drive overdose deaths upwards, which is why it is such a cause for concern. And then in terms of kind of how we in Snohomish County stack up against other counties and the state as a whole, in general, our overdose death rates, our counts are higher than the Washington state average. Until 2021, we had the highest rates. So these are, on this slide, we just have total counts, like the number of overdoses. Rates are per 100,000 population. So we're able to compare county to county rates more easily. So until 2021, we had the highest rates of any county in Washington state. In 2022, Pierce County overtook us by a little bit, but we are still have pretty high rates of overdose death per population compared to other counties in Washington state. And so the next slide of data that I have to share is from our partnership or a grant-funded partnership that our team has with 2 emergency departments in Snohomish County, Providence Medical Center in Everett and Swedish Edmonds, which account for about 80% of all emergency department visits in the county. So pretty much, catching the majority of emergency department visits. And the grant that we have allows us to work with these emergency departments to get some really critical data about kind of the conditions surrounding overdose when folks arrive at the emergency department after an overdose. So here we have data just from 2020 to 2022. And please note that the 2022 data are complete through mid-December, but are still preliminary, so not finalized and may increase. But this is really just showing kind of the total frequencies and most common opioids that are involved in when folks show up to the emergency department after an overdose. So the number of overdose visits from 2020 to 2021, as you can see, increased. So that's the first dark gray bar. So 537 in 2020 to 587 in 2021. And then I know 2022 looks like it's a lower number, but again, most likely will increase once those numbers are finalized. And then in the 4 other bars next to it, you can see the breakdown of what substances are involved in those overdoses. So heroin, prescription pain medication, there's a category for other or unknown. And then the lightest gray bar, which I'm hoping is visible, is fentanyl. And again, here you can see that even over this, this 3-year time period, it really closely mirrors what we see in overdose death, which is that the proportion of overdoses due to heroin is decreasing, while the proportion of overdoses due to fentanyl is really dramatically and very visibly increasing. And And let's see, so fentanyl is about 58%, or overdoses due to fentanyl makes up about 58% of emergency department visits. So generally these are folks who, had an overdose, were revived, EMS arrived, and were able to take them to the emergency department, versus the prior slide, which was just death. And of overdose deaths, fentanyl makes up about 87% of those deaths. So basically that is saying that fentanyl is driving not just overdose, but also increased overdose death, because, as we'll get talked about later, it is a really lethal substance and not very forgiving when folks use it and experience overdose. So another element of, or another piece of data that we get from our emergency departments is around polysubstance use, which is important. Polysubstance use is very common, and it increases health risks due to substance use and misuse. And we know that even when we're talking about exposure to ACEs and long-term effects impacting substance use disorder, that is, alcohol and a number of illicit substances, not opioids exclusively. So we certainly worth looking at data around what substances are being used in combination with opioids. So this is data from our emergency department. The Washington State, or I guess it's through the University of Washington, but the Alcohol Addictions, Drug, and Alcohol Institute, ADAI, they rebranded or changed what the acronym stood for recently, does a statewide syringe services program, drug user health survey every, I believe, year or every other year. And in their most recent survey in 2021, they also asked a lot of questions around polysubstance use, and what we see in our data around polysubstance use is very much echoed in that survey as well, in that a very high proportion of folks are using multiple substances, not just opioids. So from our emergency department data, again, this is the same 3 years we saw in the last slide, 2020, 2021, and 2022. We can see the biggest increase in the top line, which is folks who say that not only have they used overdose and had opioids and had an overdose due to opioids, they have also used methamphetamine. We can see that line really increasing from about 16% in 2020 to 24% in 2022. So that's about 1 out of every 4 overdose visits also involves methamphetamine, whereas kind of we land more in the 10% range in 2020 with alcohol, benzodiazepines, and cocaine or crack. So the cocaine, or rates of cocaine use, has also increased. That's the darkest bottom line. Whereas benzodiazepines has actually decreased a bit over time, and alcohol co-use has increased, but at a slower rate. So really we see kind of a bigger increase in cocaine use over this 3-year period, and then methamphetamine use as well. And then 2 more data slides, and then we'll move on to not talking about data. So this is just kind of to do a kind of a breakdown by age, sex, and then we'll look at race of folks who are presenting to the emergency department after an overdose. So again, from the same 3 years, 2020 to 2022, with 2022 still not being fully finalized, we see that first, when looking at age, there's a pretty clear kind of curve around who is experiencing overdoses and overdoses that end up in the emergency department. We do know that youth are impacted by overdose, and I know that's something that I think, especially in the past year or 2, has really been talked about and focused on, especially in the context of fentanyl, because fentanyl has been showing up in so many different substances that youth are exposed to, that they, in past years or eras may not have come into contact with. You know, it's certainly important to talk about youth and overdose, but when we look at the data, for the most part, the age groups that are most impacted by overdose are in the like 25 to 49 range. You know, certainly in this 3-year period, there have been teenagers who have been impacted by overdose, just as there have been, you know, much older adults who have been impacted by overdose. But for the most part, it really does focus in kind of that middle age range. And death data tends to be on the slightly older end of this, but the distribution is similar. And then when we look at sex assigned at birth of folks who are in the emergency department after overdose, about 1/3 are female, while 2/3 are male. And that breakdown is pretty similar to what is seen in the death data as well. And then finally, a very important slide in when we are talking about overdose and how we address overdose, how we do overdose prevention work, who really needs, you know, the most, who needs targeted efforts around overdose as well. This again is the same 2020 to 2022 period. I know there's a lot of numbers on here, but I think this is a really important slide. So the 4 bars for each race or ethnicity category are, the first 3 bars are 3 years of data, and then the bar that is in black is the Snohomish County, or what proportion of the county population that race makes up. So in Snohomish County, 66.8% of the population is white, but you can see over time from 2020 to 2022, the percentage of overdose has been, you know, slowly over those 3 years has become, or the number of overdoses has been less, or fewer. I'm sorry, I'm saying this not clearly. The proportion of overdoses has been less, declining for the white population. So from about 78% in 2020 to about 69% in 2022. So that means that the percent of overdoses is about matching the percentage of the Snohomish County population for the white population. However, when we look at some other kind of more like the BIPOC communities, we can see that for folks who identify as Hispanic or Latino, over those same 3 years, the proportion of overdoses that are folks who, you know, identify as Hispanic or Latino has been not only increasing very visibly, but increasing to the point where now they are overrepresented in the overdose data. So 10.8% of the Snohomish County population identifies as Hispanic or Latino, but 11.3% of overdoses in 2022 were folks who identify as Hispanic or Latino. Same when we look at some of the other categories like Black and African American, and the American Indian, Alaska Native community. The proportion of overdoses that is for those communities is much higher than the amount of the county population that they actually make up, which means that this is even over just the past 3 years has started impacting communities of color more than it was, you know, even 3-ish years ago, which for our team is really important because it tells us how we can continue to best do opioid prevention work in our community to prevent death. That is it for our data slides. Again, feel free to drop any questions in the chat, and Sarah or myself will answer them later on. But for now, I'm going to turn it over to Abby.
Awesome. Thanks, Juliet. That provides some really great context around what we're seeing with overdose within the county. So we want to switch gears just a little bit and start talking about the intersection of adverse childhood experiences and opioid misuse. So we know from a recent study by the CDC that the likelihood of someone misusing opioids definitely increases as the number of ACEs they experience also increase. So you've kind of got a dose-response relationship there. And in that same study, they explored that students with 5 or more ACEs were 15 times more likely to report opioid misuse than students who didn't experience any ACEs. And so that's a fairly significant difference there. If you want to go to the next slide. So how ACEs impact opioid use disorder. One thing we want to stress is that a certain ACE score doesn't necessarily cause or relate to the same effects, and that's not really generalizable across our population. We know that if certain people experience a certain type of trauma growing up, it isn't necessarily going to result in a certain response. However, we do know that many people express that they have used substances and opioids in particular, but it kind of goes across the board as a way of coping with the trauma that they've experienced. And so through this, we know that for children who have experienced ACEs and trauma, that expanding accessibility for support to help cope with those traumas is really, really important. And then it also emphasizes the importance of making sure that we're centering trauma-informed approaches within all the spaces that we're working with people who use substances and have substance use disorders, just because we know that the likelihood that they have experienced trauma in some way is pretty high. Okay, you can go to the next slide. Okay, so there was a study that was recently released, actually about within a month ago, of qualitative interviews. And the article is called "Things You Can't Suppress: Adverse Childhood Experiences in the Narratives of People with Opioid Use Disorder." And so basically in this study, they didn't specifically ask about adverse childhood experiences. In their interview protocol, they asked specifically about substance use, and whether they had mentioned ACEs or not came up more organically. And so around 68 of these participants and they were folks that were in treatment, or attempting to access treatment. And so around 68% of those participants mentioned an ACE in some way. And so what they did is they kind of categorized people into one of these 4 categories of how they mentioned or framed their experience with their adverse childhood experiences. And so the first one was haunted by trauma. So this is people who, when they talked about their substance use disorder, traumatic events kind of bubbled up and were causing a lot of discomfort for participants. And so their ability to even talk about their substance disorder were really disrupted by these recollections, and they couldn't really fully function without their trauma coming up. And so that was kind of one category of people. So clearly very, very present when they were talking about their substance use disorder. Another kind of grouping that they saw was folks who were seeking redemption, so that their adverse childhood experiences were really incorporated into a type of survivor's narrative. So they would mention their adverse childhood experiences within their drug use trajectories, but didn't want to be defined by them, and also articulated goals and aspirations to kind of overcome these circumstances they had experienced. The third was a pattern of reckoning with inevitability. So one is particularly with people who grew up with a family member or parents, other prominent folks in their life using drugs, and then having kind of an inevitable or unavoidable trajectory to using drugs, and kind of described a sense of resignation, beginning drugs, saying they'd kind of worked to avoid this future, but it kind of just happened to them. And then the last was casual mentioners. So as I said before, they weren't explicitly asked about adverse childhood experiences, and these were folks who maybe made a passing reference, but didn't necessarily link their substance use or disorder with their adverse childhood experiences. And so in the study, they described that these participants either were having a fully resolved or had already processed these experiences, or they were actively working to avoid them, and to have somewhat successful strategies, as they didn't really impact the person's ability to talk. It didn't, the trauma wasn't interrupting their ability to talk about their substance use disorder. And so if you want to go to the next slide. So there was also other things that really impacted how people were processing their substance use disorders, and particularly their opioid use, and how they kind of framed it and linking it to their adverse childhood experiences. One of them is around cultural values, as far as self-determination and personal responsibility. We've got an example of a man who grew up in a very middle-class white family, where he said, "Oh, it's all my own fault. I've made really bad decisions." Then he mentioned some really tough things happening in his family, but he made no link to those two, that it was just him making poor choices. And he really kind of the bootstraps mentality, wasn't able to connect his life circumstances to his substance use disorder. And we also see some situations where people, especially around masculinity, have embodied gender norms that have made it really difficult to process past trauma and how that has related to a substance use disorder, particularly around survival. And in the case of one gentleman, he felt like he had to be very, very strong and have this persona of strength to survive being on the streets, survive being in prison, and didn't feel like he could open up and talk about the abuse that he experienced as a child. And so that really attempt to appear masculine interrupted his ability to heal. And so another example of a social factor that has influenced processing around or processing ACEs and opioid use would be racism. There was an example of a Black woman who was really navigating a lot of treatment spaces that were very white. And she felt like she got less sympathy from the clinicians and the staff. And so then her white counterparts, and getting less support with her medications. And so navigating these systems for folks of color can sometimes be more traumatizing, and kind of add on to that. And so that is something that can interrupt the ability to process that trauma, and also how it impacts substance use disorder. And then the last kind of social factor that I'll mention is interpersonal relationships really, really matter. There was examples of how kind of someone was able to frame their trauma and heal from their substance use disorder, because later on their mom became more involved and really validated the assault that they had experienced as a child, and helped them kind of craft this survivor's narrative by validating the trauma. Whereas there was another woman who experienced a similar sort of trauma assault as a child, but it was a family member, and the family embraced the perpetrator and denied her reality of the abuse that she had experienced, and that she was one of the folks that was very haunted, continually haunted by her trauma. And so having the support and validation of interpersonal relationships can be really important when processing trauma and have an impact on opioid use and just substance use and coping in general. Okay, you can go. Oh, and then I'm going to go ahead and kind of on that note, pass it off to Brenna to talk about risk and protective factors.
Thank you. So I imagine we all have some knowledge with risk and protective factors. We've probably heard those terms before, but just to make sure we're all on the same page during this training, risk factors are, they can increase the likelihood that a person can experience adverse childhood experiences and or misuse substances. And then protective factors can decrease the likelihood that someone will experience ACEs and or misuse substances. So there are several different kinds of risk and protective factors for all the different categories of adverse childhood experiences. And these can exist on community levels as well as individual and family levels, but we really want to emphasize that no child or individual is at fault for any of the adverse childhood experiences that they do experience. All right. So here are some examples from the CDC of individual and family level risk factors as well as community level risk factors. This is not an exhaustive list by any means, but this is just here to kind of serve as an example for risk factors that can increase the chance for someone to experience adverse childhood experiences and use substances. So on the individual and family risk factor side, number one, family members who use substances are going to increase that likelihood of youth using substances. Families with inconsistent discipline and/or low levels of parental monitoring and supervision. Then children and youth with few or no friends, or with friends who engage in some aggressive or delinquent behavior, which could include the use of substances. And then children or youth who don't feel connected to or feel close to their parents or caregivers and feel like they can't talk to them about their feelings. And then looking at the community risk factor side, communities where neighbors don't know or look out for each other and there is low community involvement among residents, communities with few community activities for young people, and communities with easy access to drugs and alcohol. So when we look at all of these, some common themes here are lack of social structures and lack of support, lack of connection, and then the availability of substances and positive perceptions around those substances. And as has been mentioned by Abby, people sometimes use substances to cope with their traumatic or negative experiences to numb any of those unwelcome emotions. So now we're going to take a look at some protective factors. So these examples are also from the CDC and again are not an exhaustive list, but just some examples. So here on the individual and family side, we can see families with strong social support networks and positive relationships with the people around them. Children who have caring adults outside their family who serve as mentors and role models. Families who create safe, stable, and nurturing relationships, which kind of means that children have a consistent family life where they feel safe, taken care of, and supported. On the community side, it's pretty similar. Communities where families have access to medical care and mental health services. And this access also has to be affordable for people. Communities where residents feel connected to each other and are involved in the community. And then communities where families have access to safe and engaging after-school programs and activities. So some common themes that we see here are strong social support and structures, both within and outside of the family. And then also having opportunities for youth to participate in after-school programs and activities that are going to promote those social and emotional skills and are engaging to youth and, again, are accessible to everyone in the community. So what can we do to increase some of these protective factors? We can strengthen economic supports for families. So this can look like increasing household financial security as well as policies for work that are family friendly. Examples of that could be benefits that support childcare, allow for flexible work schedules and environments, so allowing for work from home, maternal, paternal leave, and then family medical leave, etc. And then promoting positive social norms that protect against substance use and promote mental health. So education campaigns that are fact-based around substance use, encouraging self-care and communication of boundaries. And then for ensuring a strong start for children, this is going to be more on kind of the societal structure end of things, but this could look like having legislation that's going to improve the quality, accessibility, and affordability of childcare. We can also teach important life skills that relate to those social emotional learning skills, having healthy relationships, and then some parenting skills or family relationship approaches. We can also connect youth to caring adults and activities. So this could look like a mentoring program or after school programs. And then we really want to emphasize that early intervention when we are noticing some signs of risk factors is going to be really important. So early intervention can mean a lot of different things, but some examples could be legislation to increase the availability and funding of family-centered and youth treatment options for some opioid use or other mental health services. So now that we kind of have that understanding, I'm going to pass it back to Juliet, and we're going to look at some ACEs in our Snohomish County community.
Thank you, Brenna. So we have pretty much one final little piece of data to look at when just trying to get a sense of the impact of ACEs on youth locally. And I say like limited piece of data because there just isn't a lot of ongoing surveillance of all of those all of the ACEs, you know, in the surveys that are done throughout the county, state, even at the, you know, United States level. So this is data that comes from the Washington State Healthy Youth Survey, which is a survey that is taken in schools throughout Washington State, including most of the schools in Snohomish County. It's taken by 6th, 8th, 10th, and 12th graders, although here we only see 8th through 12th because the 6th grade questions are a little bit different. And it's taken normally every 2 years by these even grades. COVID threw that off a bit, so the most recent data is from 2021 because 2020 got skipped because it was understandably there was a lot going on. But this is data that is updated, or we get new data from it pretty consistently. And the Healthy Youth Survey, while it does not include questions on every single one of the kind of ACE categories or those adverse childhood experiences, it does ask a lot of questions around risk behaviors, around risk and protective factors, and what they have started doing with these survey results is taking a set of 11 questions from that survey. They have a bunch of experts kind of discuss which questions should be included in this, and then using those 11 questions to kind of make their own ACEs score. So that is what is shared here, and basically it is comparing how Snohomish County looks to how Washington State as a whole looks, just to get a sense of what this actually looks like for youth in our community. So it goes from 0 to 4+. So there actually are all 11 questions captured in here. So, but kind of they condense everything that's 4 and above, just since that tends to be fewer youth who that represents, and to, you know, protect privacy, especially for looking at these results more on the school level. But so the first column for each grade level is Snohomish County, and then it's comparing it to Washington State as a whole. And you can see that kind of across these categories, like for youth who report having 0 of these, you know, questions that they're using as their kind of ACEs proxy. There are, at least for 8th and 10th grade, more students at the state level than at the Snohomish County level who report having none of these ACEs impacting them. And then as we kind of work up to 1, 2, 3, and 4, Snohomish County youth in Snohomish County tend to be impacted by more ACEs than youth across Washington State. So I think that's worth noting. And then just kind of for context, those 11 questions kind of fall into 4 categories. They kind of address safety with peers, so things like bullying at school, feeling safe at school, intimate partner violence, and experiencing any kind of sexual force, interpersonal relationships at home, and then family financial hardship. It does not include answers to, because it does not really, the health use survey does not ask questions about or super clearly about things like alcohol or other substance use in the home, mental illness, depression, or suicidal behavior in the home, incarceration of a family member, or parental divorce or separation. So I just kind of wanted to note those because I think it's fantastic that we have this data because it's better than not having any data around ACEs, but this does not reflect the actual like 10 adverse childhood experiences that generally we talk about kind of as being the set list of them. But I think it still does, you know, with the data we have, it's really great to kind of see how things change over time and how each county and community looks kind of compared to the state. And then finally, I just thought it would absolutely would be worth mentioning some of kind of the current efforts, at least on the local level, even to the state level, that are working to address ACEs. For the most part, these are all efforts that are really addressing what Brenna just talked about 2 slides ago in terms of what can be done to increase protective factors and to reduce risk factors. So the first one, I didn't want to miss this one on the list, but the health department's maternal and child health program does a lot of work around ACEs, such as putting on these quarterly events. So these are super important. In Snohomish County, there's also the Snohomish County Human Services runs the Children's Wellness Coalition, which does a lot of work around ACEs and trauma and, trauma-informed spaces as well. And then kind of more, at least coming from the state level, OSPI has a lot of trauma-informed schools resources that, of course, schools locally can participate in and do participate in. And then there's also the Washington Healthcare Authority Community Prevention and Wellness Initiative, which funds community substance use prevention coalitions, of which there are 6 in Snohomish County. And they are all fantastic groups working on bolstering protective factors, reducing risk factors in their community to improve outcomes for youth around substance use and other risky behaviors. So it's fantastic to know that we're in a community where a lot is already taking place. But we know that, more work around this topic is always needed. So I'm going to pass it back to Abby and Brenna for kind of part 2 of this to talk about understanding opioids and how to save lives with naloxone.
Thank you, Juliet. Really appreciate that. So we're going to quickly move into our technical information about opioids and overdose response. And so we just want to make sure before we go into overdose response and what you all can do if you come across someone who's experiencing an overdose, is just make sure that everyone has a shared understanding on what opioids actually are and how they work, how they affect the body. So you all may know this already, but the goal for opioids is to reduce pain. And so at different levels, they can give an intense feeling of happiness or euphoria, and also at that higher level can impact someone's ability to breathe, giving respiratory depression or reduced ability to breathe. So it's also a substance that creates tolerance. So the more you have of it, the more you have to take to get that initial feeling. So the effects change over time depending on how much of the substance you've already had. It does cause dependence. So if your body is used to having it, and if you don't have it in your body, then you'll experience withdrawal symptoms. And those can feel like the worst flu you have ever felt like or ever experienced with opioids. It can make people very, very sick if they are dependent on opioids. And at the point where people have, they compulsively use opioids, and are not meeting their family obligations, work obligations, social events, things like that, that's when we say that it has elevated to an addiction. And we call this opioid use disorder. And we really want to separate the morality around, like, are they a good person with their substance use disorder, their opioid use disorder? Because when someone is experiencing an addiction, especially of this sort, their brain is actively working against them to be able to make the good choices that they may want to do it. So it's not necessarily about someone's willpower or their morality, but more around how their brain is actively working against them because their cravings are so strong. And then we also want to mention harm reduction, and that's the idea that we believe that everyone deserves a chance to continue on with their treatment and recovery journey, no matter what stage they're on. And so to do that, they need to be alive and well. And so we want to reduce the harms such as overdose and death, and illness, such as infections, things like that, that impact someone's life or quality of life, so that they have the ability to make that next step. And so it's doing things like giving them Narcan to save their life. And so that's something that we really advocate for. Next slide. Thanks, Brenna. You were right on top of it. So what kind of opioids are there? Juliet had kind of already discussed this, that traditionally at the beginning of the opioid epidemic, we really saw that people were overdosing on a lot of prescription opioids. So we've got our oxycodone, hydrocodone, morphine. You might have heard the brand name of OxyContin. And then we also have, you may have heard of pharmaceutical fentanyl. So we want to emphasize the fentanyl that we're seeing spike our overdose fatalities is not pharmaceutical fentanyl. This pharmaceutical fentanyl is different chemically, and it's going to be highly controlled in a medical setting around like a surgery, things like that. So if you end up getting a surgery or in that medical setting, I wouldn't have a lot of fear around pharmaceutical fentanyl, as it is definitely highly controlled. Another thing we want to emphasize is there are options for people to help them reduce those cravings and lead a normal life. And it's called, we call it MOUD, or medication for opioid use disorder. And two examples would be methadone and buprenorphine. And those basically allow someone to reduce those cravings without getting high if they're used at proper doses. And so we want to destigmatize that. Some people could be on it for a short amount of time. Some people could be on it for a lifetime. And it's kind of like if someone has diabetes, then they might need insulin. And so we really want to emphasize that that is a great option for some people who are in recovery. And then we want to talk about always illegal opioids. We've got our heroin. There's no medical benefit to that, or our illicitly manufactured fentanyl, which we'll talk a little bit more soon. And then on our next slide, how do people take opioids? Right now, opioids in Snohomish County are mostly found as a pill or a powder. And because of that, we're seeing people mainly smoking their drugs or taking them by mouth. Snorting happens occasionally, but we do see a definite decrease, at least in the past 5 years, huge decrease in injection drug use. And then, of course, in a medical setting, people are given IVs, kind of a patch, different strategies there. And you see that less often outside of a medical setting. All right, pass it over to Brenna.
Thank you. Okay, so we're going to talk about a couple of situations that can create risk for overdose for someone who's using opioids. So the first example is going to be a teenager who maybe finds some opioid pills in their medicine cabinet at their house or at a friend's house, and they take them because they're curious how the pills are going to make them feel, or maybe they already know and want to experience that. And then children can also be at risk if they get into medicine cabinets that are not properly secured, because pills can look like candy. So they might think that they're just eating candy when in fact it's an opioid medication. So that can be very dangerous. Another group that is at risk for overdose are going to be people who have not used opioids for a few days or more and then start using again. So they may stop for a variety of reasons, but because they've stopped, their tolerance has dropped. And so if they go back to using at the same rate they were before, that's going to put them at an increase for overdose. Another group of people who are at risk are people who use fentanyl. So we've mentioned throughout this training, and you've probably all have some idea, but fentanyl is a very dangerous substance. It's much more concentrated than other opioids. So in this image, we can see a lethal dose of fentanyl versus a lethal dose of heroin, and it's a pretty stark difference. Fentanyl also goes through your system much more quickly than other opioids, so this can lead to people taking doses more frequently to sustain their high. And once again, taking those frequent doses are going to put them at an increased risk for overdose. And because it's so cheap, it is really saturating the drug market right now, and that's all that is available to people who are taking substances at the moment. Fentanyl can be found in pills that look identical to prescription opioids, like Oxycontin or M30s, which is that first picture there. So if anyone buys pills that look like these on the streets, or if you're getting them from anywhere that is not your doctor or a pharmacy, it's probably going to be fentanyl and not Oxycontin as it's advertised. But fentanyl can also be found in other substances. The second picture is of fentanyl that's been mixed with heroin. And then fentanyl can also be found in non-opioid substances like stimulants. So this image here is of fentanyl that's been mixed in with methamphetamine. So that polysubstance use combination has been on the rise, as Juliet demonstrated in those data at the beginning. There has also been an increase in people who believe they are using cocaine at the moment, but it actually contains fentanyl, and so there's some overdose risk there as well. And then people who do use multiple substances, they may not intentionally be doing this. They may not realize that the substances they're taking are mixed in with that has fentanyl in them or other substances. So with the example of people who believe they're using cocaine, they didn't realize that fentanyl was in there, and so that's a dangerous risk. But there are people who do intentionally use multiple substances as well. And the combinations of substances are always going to be much more dangerous when they're mixed. So now we want to talk a little bit about some fentanyl exposure safety. There's been some misinformation floating around about this, and so we just want to clear the air and hopefully reassure you all, but you are not at risk of an overdose if you're helping someone who's overdosing from fentanyl. The American College of Medical Toxicology and the American Academy of Clinical Toxicology released this position statement in 2017 that says fentanyl and its analogs are potent opioid receptor agonists, but the risk of clinically significant exposure to emergency responders is extremely low. To date, we have not seen any reports of emergency responders developing signs or symptoms consistent with opioid toxicity from incidental contact with opioids. So that's just really reassuring that you're not going to come in. If you're exposed incidentally, meaning you're not intentionally taking the substance, you're really not going to be at risk. And reversing an overdose is a time-sensitive intervention, so the sooner that we can intervene, the better the outcome can be. And so this information can sometimes cause delays in our response, and we really want to make sure that we're not having any delays. We need to act as quickly as possible. So some more information here. It is effectively impossible to overdose from touching it. Fentanyl has to enter the bloodstream in order for a person to be affected by it. It's not very water soluble. It doesn't pass through the skin very easily. There are those medical fentanyl patches that are designed for people with like chronic pain. And those are specially designed in order to allow the fentanyl to pass through the skin. So they really had to make that intentional design choice for that. And then fentanyl is going to be most efficiently absorbed through the mucous membranes, which are your eyes, nose, and mouth. However, it's really unlikely that fentanyl is going to come in contact with your face by accident when you're responding to an overdose. But some additional things you can do to protect yourself is, not touching your face or mouth or anything like that while you're on the scene of where an overdose occurred, and then washing your hands with soap and water afterwards. Soap and water is a perfectly fine way to wash off fentanyl from your body. We want to avoid using sanitizer or any other alcohol-based cleansers because that can increase the absorption of it. And then fentanyl does not linger in secondhand smoke. The person who is smoking it is going to receive the majority of the substance, and then it doesn't really linger in what's released. So that's not a concern. And then fentanyl also does not easily become particles in the air. So if there are fentanyl particles in the air, they're going to be very, very small. And it's estimated that it would take about 3.5 hours without any respiratory protection for the body to accumulate a detectable amount of fentanyl. So that's not even at the risk for an overdose level. So hopefully that helps reassure you all that it is completely safe to respond to overdoses where people are overdosing on fentanyl. Okay, so we're going to look at some opioid high versus overdose symptoms here. So when we're looking for an overdose, the things we really want to keep an eye out for are if they have pale or clammy skin, if they're not breathing or have very shallow breathing, they may have some deep snoring or gurgling noises that they're making. They will be unresponsive to someone calling their name, shaking them, performing a breastbone rub. They'll have a slowed heartbeat or pulse. And then people who have whiter skin complexions are going to have this bluish color around their fingertips and lips. And then people who have some darker skin complexions are going to have an ashy coloring around the fingertips and lips. And then people will also have small pupils. If someone is high on opioids but not yet overdosing, we want to keep an eye on them. This could escalate into an overdose, so we want to make sure that we're not leaving them alone, and we always encourage people to never use alone. So how do opioids impact breathing? This is an image of the brain that represents the opioid receptors in it that affect someone's ability to breathe. So in this image, those receptors are the corkscrew kind of shapes. And when opioids go into the body, as you can see here, they end up in the brain and they connect to those receptors. And if enough of opioids connect to those receptors, the person's breathing will slow and then it can stop. And that is what an overdose is. If someone isn't breathing oxygen within 3 to 5 minutes, brain damage is going to start to occur, and then oxygen starvation can lead to shutting down some other vital organs. So that's why we say that this is a really time-sensitive matter, and we want to be responding as quickly as possible once we recognize an overdose. So now we're going to talk about what Narcan is and how it works.
Excellent. Thanks, Brenna. All right. So Narcan, if you want to go to the next slide, it is a medication that we want to give right away to reverse a possible overdose. It starts working in 1 to 3 minutes, sometimes more of the 2 to 3 range, and the effects of it can last for 20 to 90 minutes. One thing you might hear is the term naloxone versus Narcan, and Narcan is more of the brand name, where naloxone is the actual medication. So there are different forms. This is the most user-friendly. There is an intramuscular form that you would inject, so that might be called naloxone, whereas this is the more user-friendly version called Narcan. And how does it work? So basically you would press it kind of like it's a nasal spray that you press into the nose. If you want to just hit the next button, Brenna. And so it goes and it basically has a stronger connection with those receptors than the opioids do. So it knocks the opioids off their receptors and allows the person to begin breathing again. And so this is really cool because this is the only thing that Narcan does. It only works on these very specific opioid receptors. And so if someone does not have any opioids in their system, there's going to be absolutely no effect at all. If I were to grab Narcan and put it up my nose right now, it wouldn't do anything. And so what's really great is it kind of takes all of the risk and hesitation out of acting. If you find someone who's down on the ground and you're not sure if they overdosed, what they overdosed on, it's always a safe bet to use Narcan or naloxone because we know that it only works on these receptors. The downside is if someone has overdosed on another substance, it's not going to have any sort of positive effect. And so especially within those polysubstance or multiple substance overdoses, we know it only works on the opioids. All right, next slide. Some more information about our Narcan naloxone. So each box contains 2 doses, and it does expire after 3 years. However, we always say that keep your old Narcan or naloxone as a backup. We've seen studies that show that there is still effectiveness with this medication, sometimes for years. And so keeping it, obviously we want you to have up-to-date medications on hand, but if you don't, expired Narcan is always better than no Narcan. Another thing is it's best to be kept at room temperature, and that's how it remains most effective for those 3 years. And so we always caution people against keeping it in their car, especially regularly. If it happens every once in a while, it's totally fine. But if it's in the wintertime and the medication inside is freezing and unfreezing and freezing and unfreezing, or I know that cars in the summer can get very, very warm, as we never want to leave our pets in the car, those kind of situations. And so just think about the Narcan in the same deal. It's best to be kept in a bag or someplace on you if you have a chance of coming across someone who might be overdosing. Another thing is that Narcan can't be abused or cause an overdose. We know that increased access, it has very safe studies that prove its safety, and also increased access to Narcan has shown to not increase risky behavior around opioid use. And so that's something that even if there is Narcan around, people don't tend to change their use habits. And then also, so it doesn't increase later drug use also if it gets used on someone. And then also, it is approved for pregnant women in limited amounts. The way that we describe it is obviously if someone is pregnant and using, we would rather them and their baby be alive. There are some chances that the person could be in acute withdrawal and experiencing some of those really terrible flu-like symptoms. And so it isn't great for the baby either. And so we want to just make sure that people are getting checked out by medical professionals as soon as possible if someone who is pregnant and dependent on opioids is receiving this. All right, next. All right, so you may be asking, how and where do I get Narcan? So there's no personal prescription required, even though it's technically a prescription medication. We have a statewide standing order that just got renewed that is never going to expire, which is great. It basically is signed by our state health officer and has said that anyone can get access to Narcan and naloxone, the injectable as well. And it is covered by most insurance plans with varying degrees. So if you have any state insurance, Apple Health, Molina, it is going to be anything on Medicaid is going to be completely covered for free. However, if you have private insurance, it really depends by insurance. Normally there's a copay, and the copay could be $20 to $30. It could be upwards of $100. So we know that people with private insurance, that it isn't always super accessible. And so that's something that we want to make sure people are aware of. We really don't have a list of what insurances have what copays. Wish we had access to information like that, but we always tell people just contact your own insurance. But without insurance, the cost is pretty hefty, $125 to $160. And so this is one of the big things that we are currently working on, is how to make Narcan more accessible. So a current resource that we're pointing people to is the People's Harm Reduction Alliance. It's a nonprofit in Seattle, and they're mailing people free Narcan around the state of Washington. So you can go to their website and fill out a form. But we're also working on increasing availability within our schools and community organizations within Snohomish County. So if you have an organization that wants to have Narcan in your lobby, we have the funding to give each physical site a kit of naloxone. And so that's something that you can go ahead and reach out to any of us, and we'll be able to give that to you. And so, yeah, working on making that more accessible. And now I'm going to take it over to Brenna to explain how to use it.
Thank you. Okay, so taking action, the 4 R's, and we'll go through this a little quickly just to make sure that we do have time for questions at the end. But the first thing we want to do is we want to recognize any signs of an overdose. Once again, they will be unresponsive, little to no breathing, gurgling, slow or no heartbeat, pale and clammy skin, blue or ashy fingertips and lips, and those small pupils. We want to get a report from others who may have saw what happened. We want to understand if the person has a history of opioid use or overdose. People who have overdosed before are more likely to experience an overdose again. We want to see if there are any nearby medications, illegal drugs, or drug use supplies around. Really anything that's going to kind of help paint the picture for what happened and give us that context. But if we notice any of these things, we can ask the person if they are okay really loudly. You can shake them. You can rub their sternum or their breastbone with your knuckles. So you just take your knuckles and rub that along the sternum, and by pressing down, it's a pretty painful external stimuli. It's not going to cause any damage to them, but it's painful enough that if they're not responding to this, it's a good indicator that it's time to react and respond. So what does respond look like? We want to call 911 for help. To make this call a priority, you can say that you are with a person who is not breathing and is unresponsive, and then give super clear details of your location so they can find you really easily. The Good Samaritan law does protect both the person overdosing and the person calling from drug possession charges, which includes the use of substances. But it's not going to protect against any other crimes or charges. So important to keep that in mind. So if possible, you do want to delegate the task of calling 911 so you can continue with the next steps as quickly as possible, which is going to be administering the Narcan. However, if you're alone, you can put the call on speakerphone and administer Narcan while you are on the phone. When the paramedics arrive, you want to tell them as much as possible about the drugs that the person might have used so that they can get that person the best medical care. So then we move on to reverse. So we're going to peel back that package that contains the nasal spray device. We're going to place the tip of the nozzle into either nostril until your fingers touch the bottom of the person's nose. And then you're going to press the plunger firmly to release the dose of naloxone or Narcan into their nose. Naloxone goes directly into the lining of the nose, so they do not have to be breathing for this to be effective. And if you have to administer multiple doses of naloxone, you want to wait the full 3 minutes, see if they respond, and then switch nostrils and repeat as necessary. But ideally, we want to be using as little Narcan as possible, because the more you use, it is going to make those withdrawal symptoms worse for the person. But of course, we would rather that they are alive and uncomfortable. So that's that little caveat. And then we also want to make sure that we're not testing or priming the device before putting it into the person's nose. You can waste all or part of the medication by doing so. So you really want to just make sure until it's firmly in their nose until you press the plunger. If you are trained, you can give CPR, and if you determine it's needed, and once again, if there's no response within 3 minutes, you can give that next dose and continue CPR. If they do start breathing, we can put them into the recovery position, which is this image on the screen, but they are going to be on their side with one arm bent up and out, with the other under their head, and then their top leg bent. This position is going to keep them on their side, and it prevents them from choking if they vomit. Once again, we never want to leave the person alone. However, if we do have to leave them alone for any reason, say to let paramedics into the building, this is the best position to leave them in. And then next we want to refer. So we want to make sure that they are being transported to the nearest medical center, even if their symptoms do seem to be getting better. And this is for a few reasons. So if the opioid dose was too strong, the Narcan you gave them can wear off, and they can slip back into an overdose and stop breathing again. Remember, a Narcan is only lasts 20 to 90 minutes. So it is a temporary solution. And then the person will be in withdrawal after getting Narcan if they are a regular opioid user. And at a medical clinic, they can help manage those symptoms and make the person more comfortable. And then the hospital can also assess for any other medical needs that need attention, such as injuries or mental health challenges. After the person is doing okay, and if you know them, you can follow up with them about seeking treatment if they haven't been referred already. We want to keep in mind, though, that treatment is most effective when the person is ready for treatment. So we don't want to force them into it, but we just want to have those conversations with them so that they know what options are available and that you are there to support them when they are ready. There is this Washington Recovery Helpline phone number on the screen there. That is an amazing resource. They have interpretation services in over 200 languages, and they can help with the person who has an opioid use disorder or family members or friends of that person. And then self-care is really important when you're supporting someone who's overdosed. This experience can be stressful and it can be traumatic and bring up some hard emotions. So we do encourage that people find someone to talk about their experience with, whether that's a family member or friend or a mental health professional. But while you're having those conversations, we do want to make sure that we are protecting the privacy of the individual who overdosed. And finally, what more can you do to prevent opioid overdose? We can talk to our family and friends about medication storage, which is kind of what that top image is getting at there. We want to keep medications up high and out of reach with children with a child-proof lock. It's important to remember that child-resistant containers are not child-proof. So investing in a medication lockbox is the best option. There are some other like locking bags, and you can find most of these on Amazon. And then we also recommend getting rid of old, expired, or unused medications. We do not recommend flushing medicine down the toilet or throwing them in the trash. If we flush them down the toilet, they can stay in our water systems, and they're not removed, so they're going to impact our fish and wildlife. And then if we throw them in the trash, they can still be accessible to children and animals. So there are some drop boxes around pharmacies that you can use to put your medication in, which is that bottom image on the screen. Or you can call the Med Project at the phone number on the screen, and they can send you a mail-back package to your home for free. And you can take back a variety of medications, not just opioids. I know Abby's family has used this resource in the past and found it very helpful. But that is the end of our presentation. And I realized that we forgot to put a thank you slide at the end. But here we are. So I'm going to stop sharing my screen so I can pull up my video of everyone. And any questions?
So we did have one question in the chat from much earlier asking whether the slide deck will be available. I know the recording will. Yes, we can send that out. Awesome. So
Yes, we
April,
will.
we will be sending that out.
Yeah, we'll
Thank you.
send that to you at the end of this. Yeah.
All right, and it looks like Rachel's raising her hand. You can go ahead and unmute.
Hi there, thank you. So I'm a social service specialist at the Everett Community Service Office for DSHS, and we are running into a lot of drug use in the vicinity of our lobby and things. The question I have was kind of a gray area and a scenario that we came across. So we do have Narcan, and there are employees that are trained on administering it, that sort of thing. We had an instance where the person was kind of in and out of consciousness, and so we got it out, and it was in the parking lot, and so we got out the Narcan and went out there because his friend had gotten us and said, hey, we need some help out here. And he was kind of in and out, and he refused. He did not give, he said he did not consent to it. So, and then he would kind of nod out again, and then he would come back. So I just, it's good to know that it can't harm him, but before administering, then should they be pretty much unconscious and unresponsive? And so in and out, it wouldn't be appropriate to administer at that point. Is that right?
I mean, I think you can make a judgment call with some of those situations, but if they're unresponsive, that is the time that they are overdosing, and when Narcan is going to reverse that overdose and help them breathe. If there are issues of them saying they're not consenting to naloxone, if they're upset about that, the Good Samaritan law is going to protect you, so you don't have to worry about that liability as well.
Yeah, and I knew about the law too, but I'm like, well, that kind of, I mean, at least where Narcan is concerned, seems like it would kind of be if they're not responsive and you're trying to help them, but he is responsive and saying, I don't want it. I thought, oh, I don't know about the legality of that, right? And so I guess he is responsive in that case, and so not giving it to him, I suppose, would still be okay.
Yeah, and then you can keep an eye on them because they could slip, like become completely unresponsive, right?
Right, and then you can do it.
Yep, yeah, but keep monitoring them. You could still, keep an eye on them.
Okay, thank you so much. I sure appreciate it. There's certainly a big problem out there right now, so thank you.
Yeah, thank you.
Thanks, Rachel. Yeah, if anyone is awake enough to be able to say that they don't consent, it means that it isn't the appropriate time to be using Narcan. Because there is, even though it's not going to necessarily harm them, in that case, if you were to give naloxone to someone who is presumably dependent on opioids, they're going to start feeling pretty bad pretty quickly. And so that would be why they would refuse or not consent to it, would be that it could be fairly unpleasant for them to experience. So,
and Abby, it would probably be important to add there too, is if you do Narcan somebody that's not quite ready to be Narcans in that way, they might wake up swinging and they might become so agitated that they get violent. So it's always best to really pay attention to that breathing. And if they don't have that respiratory depression, if they're breathing consistently and clearly, then that would, that's going to be kind of the big indicator right there. They call it the death rattle, and they call it that for a reason. It's that almost think of somebody like almost pneumatic, like if somebody had pneumonia and they had the rattle to their respiration and it was inconsistent. That's definitely going to be a really clear indicator that it's time to get the Narcan out.
Thank you, April. Always appreciate your input.
Hey, Juliet, will the slide decks be available that has the data on it?
Yes, the slides that go out should include all of the data, but as always, if you need more data, you can always reach out to us as well.
Oh, you know I will be. I love me some data. So Abby, I would also love to work with, I want to start initiating out in the field to where there's clusters or groups or encampments of folks that are using as part of the Leave Behind program, making sure that they're trained on the basics as we're distributing it. I mean, I know we all try and tell them as we distribute, but like if we can get enough of them that are coherent enough together to really ensure that they understand that the Narcan's going to wear off before the fentanyl does. And if you had created any kind of precipitated withdrawal, or they started like, oh, I lost my high, and they went out and used on top of it, that what a risk that presents to them. And I think that that's what's most widely unknown or misunderstood out and about amongst users, is that Narcan is not going to last forever, and that will wear off within 20 to 60 minutes, and you could be in full overdose all over again.
Yeah, definitely. I think when Brenna is doing that program, I think that would be a great thing to make sure to emphasize, particularly with users.
We have created some pocket resource guides, or I should say we have updated our current pocket resource guides, and those do have some information on there about how to use Narcan and how it works and all that stuff. So hopefully that will be helpful in aiding those conversations.
So quick question for you, because I had a training with Sean Hemmerls from the Washington State DOH, and he didn't know. So I've experienced where we've gone to do nasal Narcan, and there's a lot of mucus. In one particular case, it was like literally hanging out of the nostrils. Do you know, I know, great visual, guys, but do you know if we just went ahead and shoved it up there, is it still gonna hit enough of it to hit the capillaries to be absorbed, or is that mucus gonna block it at all?
I think that might be kind of in the same lens of us not being physicians or medical professionals. We also, I'm making an assumption for the rest of the team, don't actually know the answer to that question, but that's something that we can follow up with some of our medical professionals in the county who do more work specifically with folks who are experiencing addiction. One thing is, in a lot of those medical settings, and with our EMS, they often will use injectable or
Right.
IV naloxone, and so they wouldn't necessarily experience that same barrier. But I am positive that there's some publication or information on that somewhere, so we can go ahead and look.
I would just love to add that to any kind of trainings out in the field, because it does happen, in particular during the cold months, and people who are unsheltered, that could potentially be a risk. And I haven't been able to find it, and I really haven't dug very deep though either. So
Yeah, we can definitely look into that.
Would anybody else like to ask any questions? We've got a few minutes left here. Yeah, Dennis.
Yes, I retired from the Granite Falls Community School District, and I'm currently with the Community Coalition there. I was wondering if you do presentations for the schools and communities like that.
You said it was from the Arlington area?
Pardon?
The Arlington area that you were asking about specifically? Granite Falls? Okay. So I know that we have been wanting to kind of ramp up our community presentations. We've been working with Edmond School District to have some family presentations. They reached out to us. I know that we recently presented to Arlington School District to their bus drivers in their community there, and they're increasing coverage at the schools. But that's something that we are very happy to do any sort of presentation for any group that requests. We do have a request form. Let's see if, Brenna, would you mind dropping that in the chat? And we can also email it out to all of our participants if you have a group that would be interested in a presentation around our training on how to use Narcan and opioid use. And we'd love to facilitate that for you.
I think we'd have two interests. One, presenting maybe to our community coalition monthly meeting. Be a short presentation, maybe. How long is your regular presentation?
We normally, we can do anywhere from, I mean, shortest we've ever done is 30 minutes. I would say 45 to an hour is more realistic to cover all the content we normally do, but we can kind of work within group schedules.
And the second question I had was with the schools regarding having the Narcan. You indicated you can help with getting that and maybe also doing some training. And is that something you could do, go out to these rural communities like Grand Falls?
Yeah, definitely. Just submit a request or send us an email and we would be happy to do that.
Okay, I'll consult with the folks out there and we'll get a hold of you then. Who would I contact?
I think I would probably be the best person. I'll type my email just for school related work specifically.
And
email
when this,
oh, thank you.
Sorry, when the slide deck goes out, I am adding one slide to the end that has just our opioid team email. So if you email SHD opioids, it'll go to Abby, Brenna, and myself, our whole team, and we'll be able to figure out who's the best person to respond to the question or request or whatever.
Could you send that to me, the contact?
Yeah, that will be, they'll be in the slides that get sent out.
Okay.
And
it's going in the chat as well, just in case.
Okay. And in the chat is also the link to the request form. And when you submit that training request form, that does get emailed over to Abby and myself.
Do you need my address or email?
The form.
Go ahead.
The form does ask for an email address, so we can follow up with you to schedule it. Or if you're emailing us, then we'll have access to that.
I didn't get that. I'm sorry.
The form does ask for your email, so we can follow up and schedule that training. Okay. Or you can email us directly through the emails in the chat.
Okay. Thank you very much.
Well, thank you so much for the questions. Really appreciate your engagement on this.
So it does look like we're about out of time here, but you will receive the slide deck. There will be a recording of this, and I believe they welcome any follow-up questions that you may have at a later date, and you're encouraged to reach out with those. And we just want to thank you all for your time and for joining us this afternoon.
Thank you.
Thanks, everyone.